So hi everybody, my name is Anna Sureda. I work in Barcelona, Spain, and I'm going to discuss with you the most important results of an oral communication I gave at the last EHA 2022 meeting, talking about ZUMA-7 and the elderly population of patients that were included in the trial. As you may remember, ZUMA-7 is a phase 3 prospective randomized clinical trial that compares face-to-face axicabtagene versus the standard of care, salvage conventional chemotherapy plus autologous stem cell transplantation in patients with aggressive non-Hodgkin's B-cell lymphoma that have been primary refractory or that have experienced an early relapse after first-line treatment strategy. So these patients were randomized 1-to-1 to receive either axicabtagene or the standard of care. Of note, no bridging chemotherapy was allowed in the design of the trial. No crossover of those patients that failed the standard of care to receive axicabtagene within the trial was allowed either. 359 patients were included in the trial, and the primary endpoint was event-free survival by an independent review facility. So in this presentation, I gave the results in terms of efficacy, toxicity, and patient-reported outcomes of those patients that were included in the trial with 65 years of age or above, up to 81 years. And this population of patients represents 103 patients, and this was a pre-planned and predefined subgroup analysis in the design of the overall trial. So the first information I want to give is that, as it happened with the intention to treat population of patients, more than 90% of this elderly population of patients that were randomized to the axicabtagene arm actually received the CAR-T, while only 36% of the patients that were randomized into the standard of care arm were consolidated with an autologous stem cell transplantation. And the main reason for not reaching the autologous stem cell transplant was basically because the patients did not achieve either a complete remission or a partial remission with the standard of care salvage chemotherapy. The second piece of information, which is important, is that in this elderly population of patients, the experimental arm also gave better results in terms of event-free survival, which is the primary endpoint of the trial. So with a median follow-up of 24 months, 2 years, the event-free survival of those patients being treated with CAR-T was significantly superior than the event-free survival of the patients that were treated with the standard of care. And in the same way, the overall response rate, the complete remission rate was significantly better in the experimental group, and also the overall survival, although the data that we have regarding overall survival are not consolidated enough just because of the still somewhat short follow-up. But in this pre-planned interim analysis, the overall survival also seemed to be better in the experimental arm, even taking into consideration that although crossover was not allowed within the design of the trial, more than 50% of the patients that were randomized into the standard of care treatment, upon relapse, they were treated with some sort of cellular therapy as a third-line treatment strategy. If we look at toxicity and side effects, we have to say that the toxicity profile in this elderly population of patients was quite similar to the one that we saw in the intention to treat population of patients. Although there was a slightly higher incidence of grade 3 and above CRS events, and also a slightly increase in grade 3 and above neurological toxicity. But if we compare the overall toxicity of those patients that were treated with CAR-T versus those patients that were included in the standard of care treatment, the toxicity profile in general favored the CAR-T cell treated patients. Finally, what about the patient-reported outcomes, which is one thing that is being taken into consideration in most of the prospective clinical trials that we have nowadays. So the quality of life was basically measured using the URTC questionnaires that have been universally validated. And if we look at the different endpoints that were analyzed when talking about patient-reported outcomes, All these endpoints favored CAR T cells over the standard of care, both at the 100-day time point and also at the 150-day time point. So basically, in conclusion, this pre-planned subgroup analysis of patients included in the SUMA-7 trial that was specifically looking at the elderly population of patients indicates that even in this group of patients, the use of CAR T was associated with a better long-term disease outcome. The toxicity profile was acceptable and was the one that we already know with the use of axicabtagene in similar population of patients, and the patient-reported outcomes also favored the experimental group of patients. I think that these results are specifically important because when we think about the elderly population of patients, those patients that have primary refractory disease or those patients that have an early relapse after achieving a complete remission, they really don't have, at least up to now, curative treatment strategies, and the long-term outcome and the prognosis of these patients is very poor. So the possibility to use CAR T cells in this specific group of patients really opens a different way to treat this disease, and of course it significantly improves the long-term outcome and the landscape of this specific group of patients. So thank you very much for your attention.